challenging for the doctors and challenging for the elders. It is also a challenge for the doctors. आपको हैरानी होगी ये बात सुन के. It is a challenge for the doctors and it is a challenge for our elders. आदत पड़ जाती है दवाइयां लेने की. And there are so many patient factors, there are so many doctor factors, there are so many circumstantial factors, जो कि पॉलीफार्मेसी का मतलब है प्रिस्क्रिप्शन की दवाइयां 5 से ज्यादा लेने में. It is called polypharmacy. And they can be very harmful, they can affect quality of life. और मैं ये हेजिटेट नहीं करूंगा बोलने के लिए कि ये जो शब्द है पॉलीफार्मेसी, I have many doctor colleagues on this program. Let them ask themselves, do they actually know what is polypharmacy? And I can say it with certainty, not everybody knows कि polypharmacy होती क्या है. So it's a very important topic. It's very challenging for the doctor and the patients. And let us hear today from a very distinguished and accomplished academician. We are privileged to have all the way from not Bangalore, but from Bijapur. He is none other than Dr. Anand P. Ambali, who is the professor and head of Department of Geriatrics at the BLD deemed to be university. And it is a pleasure, sir, to have you over with us, and you having agreed to spare your time as an academician amongst all the elders from Delhi and around. It's a great pleasure and welcome to you. Dr. Ambali, please, you may please start your presentation.
Try to know what is polypharmacy and apart from what only polypharmacy is an issue or something else like irrational combinations and cascade, what is happening. And as you rightly mentioned, identifying and preventing polypharmacy is one of the biggest challenge for geriatrician here. And there's an entity called deprescribing. That is what we practice in geriatric care as well. And how to improve compliance. There are some situations where older persons will have to take multiple medicines. That it becomes a rational polypharmacy. So in such conditions, how we can enhance the compliance. So what we are doing in our setup, and we will discuss and we'll take the examples from others as well. So William Osler, way back, he mentioned that imperative drugging, the order of medicine for every malady, is no longer regarded as chief function of the doctor. This is the statement you made when you called to me for the first time. You said this to me, but of course not the same words, but you mentioned what exactly this word means. So this is what is happening, sir, nowadays, and that is how we will try to address the issue. I'll just bring an example to you. This patient had come to me. We are not interested from where it has come. But what is happening here is, look at the number of medicines they are taking, 22.
22, my
Yes.
God.
And in that only one is an local application, gel, and one is injection. Rest 20 medicines are to be swallowed every day. Okay.
My God.
So in this patient, I just asked him, how is your appetite? He said, डॉक्टर साहब एक दवाई से मेरा पेट भर जाता है, अभी खाने में जगह ही नहीं है. So I don't have any space to eat. These medicines, my stomach gets filled. So now why this is important from a geriatrician point of view and a clinician point of view, because if you see here, there is a duplication or multiplication of the same class of drugs. So the first, if you see a 2 here, it is an esomeprazole, it is antacid. Here also they are giving ranitidine with domperidone. So 2 drugs of the same class are being prescribed. So that should not have been done. Then if you look at the blue dots, one is here and another is the corner. So most of the medicines that the syrup that containing all are on the GI tract, which suppresses the acid levels, and some like aluminum sulfate and bacum, they are more harmful to the older persons because of the low pH in the GI tract. And the most important aspect in this was, if you look at the yellow dots. So the 5 yellow dots all are the combinations of one or the other multivitamins. So the question is, does that old man require all these things? And with such a combinations, so 5 medicines are only for multivitamins out of 20. So this was filling his stomach and causing more problem than his health. So we have to remember what Hippocrates told long back: let food be thy medicine and medicine be thy food. So as you are mentioning that, yes, good food, good health, and less unhealthy food, more medicines. So that's how we can take up. Now, this is a person, old patient had come to me, and we just asked him, show us the medicines that you are taking, and we want to ensure that his compliance is maintained. So when I told him to show his medicine, he just opened one pack and just put it on my table. So these are the medicines I'm taking. I said, wow. Then how will you identify which medicine is which? How will you take it? And slowly, one by one, he opened and he said, the one with the red strip, one with this fold I take in the morning, one in the afternoon. So this is how some older people are extra smart. They manage to take medicines. But look at the way he is taking. When we are talking about boxes and all, pill box and all, and he has his own way of taking medicines. So we have to respect, but I only ensure that he is taking the prescribed medicines regularly. So as sir put the theme, polypharmacy means, so anybody can answer. That's too many drugs, drugs for too long time, drugs in exceeding high dose, all of the above, or only A. You can put the answer in chat box, or you can even unmute and say all of the above. Okay.
No. 2 minutes. 5 drugs, 5 or more.
Yes, sir. You are right, sir. So too many drugs. You are right. So as sir told in his opening remarks, it is more than 5 medicines. And yes, the answer by Mahesh sir is right. Too many drugs. So now the concept of polypill is there. A single pill of the Ecosprin Gold or Rosuar Gold that you are taking, it has 3 medicines. So that also matters. So you are taking 3 medicines. So it's not only one medicine, it is 3 medicines in one pill. So that adds to the number of drugs you are taking. And why it is important, we will discuss. So as sir mentioned, polypharmacy and is the more use of 5 or more medications. This includes over-the-counter prescriptions and traditional and complementary medicines and all those things. So why it is important, as sir mentioned, and we take it as a very serious issue because we classify polypharmacy as a geriatric giant. So geriatric giant concept is the one that any giant, there are 5 giants, can be a presenting feature of serious health illness. So for example, a patient with polypharmacy can present to you with a history of falls. So that is the one meaning of giant you can take, or a state of confusion, or more medicines and some drug-drug interactions can lead to electrolyte abnormalities, and they can present to you with the state of acute confusion. Now, some of you may say that, sir, there are older people, they have more diseases, they meet more consultants. So definitely more medicines will be prescribed. Yes. So of course, this if you see on the right hand side of the top page of the British Medical Journal that was published in 2012. Now they have mentioned that forget the system. The consultant for each disease is there. So you boards are there for each disease. Forget the system. Earlier, CNS के लिए जाओ, cardiovascular के लिए जाओ. अभी नहीं. So individual disease you have to go for. Definitely, by the end of the day, when you come back to your home, you're consulting many consultants, you will end up with polypharmacy. Now, our concern is whether this is an rational polypharmacy or irrational polypharmacy. That is what we should understand in this scenario. Okay, so our responsibility is to avoid drug related problems. No matter, okay, if you have cardiac problem, you have got diabetes, you have got hypertension, you have got ischemic heart disease, you have got hypothyroidism, prostate hypertrophy is there, fine. But in those medicines only, we have our responsibility to avoid drug related problems, and we should always ensure functional and cognitive status has to be maintained and assessed before we prescribe medicines for the older persons. Now, why it is taken so much importance? Because there are huge number of older people getting side effects or adverse drug effects, and they are coming for admissions in the emergency wards. And 70% of these hospital admissions are one patient over 65 years of age and 5 or more medicines. So polypharmacy is definitely an issue to be addressed and to be prevented. Irrational polypharmacy has to be addressed day in and day out. Now, when there is a polypharmacy, there is something called hyperpolypharmacy. If person is taking 10 or more medicines, it is called hyperpolypharmacy. And this has been increasing slowly now. So more people are living longer and longer, 85 years, 90 years, 95 years. And definitely they will have 6 to 7 comorbidities. So they'll end up with taking 10 medicines in a day, which are definitely required. So that we call as hyperpolypharmacy. So what are the risk factors for polypharmacy? Again, increasing age. Some physicians, as sir told, have prescribing habits, right? More drugs, more medicines, more medicines. Okay. And of course, there is a system now, guidelines-based system is coming. But guidelines says that for a heart failure, you have to give 7 medicines. But all does it? It is again depends for the cardiologist or the clinician to decide whether should I give all the 7 medicines for this patient. Can he tolerate? He is frail. He is sarcopenic. All these issues we have to consider. So for each guideline also there is an ascetic mark subject to the patient's health, or if the patient doesn't tolerate, you should stop. Now, what should be our goal as a geriatrician, as a physician or family physician, as sir is practicing? We should reduce inappropriate polypharmacy. We are not against polypharmacy. We should reduce inappropriate polypharmacy and ensure appropriate polypharmacy. This is very, very important. If polypharmacy is there, 5 medicines he is taking, but ensure he is taking with a good compliance. But if irrational polypharmacy is there, reduce it. Provide holistic and comprehensive approach and ensure adherence. This is very, very important to, and report immediately the adverse drug reactions to the patient. Now, if you just go through this statement, what is written here is under-prescribing or over-prescribing is an important clinical issue, because patients with polypharmacy have an increased likelihood of not receiving potentially beneficial medicines. This is what happens. This is why we are worried about polypharmacy. The medicine actually required by the patient, he will not consume. Okay, so he will think that these, and most of the older people, they think, looking at the cost factors, the cheaper they are, they keep with them. The costlier they are, they think, oh, it's not required. So again, this is a decision taken by the patients. So when there is an irrational polypharmacy, the chances that patient not receiving potentially beneficial medicine reduces. So this is very, very important. We have to take care. So as we are addressing multiple morbidities in the older people, they seek pill for every ill. They go on complaining multiple complaints and they want a pill for every ill. That should not be practiced. Some older people are fond of alternative medicine, but again, mixing with the allopathic medicine is hazardous. On the counter medicines and in the morning walk, when most of the older people, they go for a morning walk, they discuss with the other colleague, I have a joint pain, still not reducing, which medicines you are taking. So he will advise that, oh, my doctor has given this medicine for me, why don't you try? But again, we should not be done, because certain medicines are tailor-made for the patient. If the patient is having hypertension or diabetes, we don't use diclofenac sodium, which otherwise should not be used in these diabetic and hypertensive patients. So that is how your doctor is the best decision maker. and some medicines which are addictive. They say that no, I'm taking Neurobion for last 5 years. I want to continue. I feel better with that. Okay, fine. I am taking alprazolam every day night for last 10 years. I am comfortable with that. So this is how the issues pop up in the older persons. Now, how the chance effect takes place in the clinical scenario. What my patient says. If I write only one medicine for all his complaints, he feels that "Arey, doctor is not intelligent. I think he's okay. Probably has not understood my problem. He will go and tell his son, ensure that doctor has understood my problem. How can you write only one medicine for so many problems? Okay, so more drugs. Oh, both doctor both badhiya hai. So that is how they think of. If you write more drugs, they think, oh, doctor is so intelligent. So if you tell them to stop the drugs, they will tell, no, sir, my old doctor has told not to stop till I die. So they keep taking, that becomes additional drug. Herbal and Ayurvedic medicine, they say that there are no side effects, but you know, all of you know that a lot of side effects are popping up now. And most of them will ask for a sleeping pill. I am not getting sleep. Can you write a sleeping pill? But again, Dr. Saab, will it cause addiction for me? So these are how the people they want solution, and they again question the role for the medicines. So that is how the practice goes on in the geriatric care. Now, what is the impact? Adverse drug reactions are very common. Hospitalization, increased mortality, falls, confusion, incontinence. All these are the drug impact of polypharmacy on the older people. Cost factor, of course, it will increase. Non-adherence, they will not take all the medicines. Non-compliance, drug-drug interactions will be more. Prolonged stay in the hospital, and because they are taking more medicines, they eat less. That leads to undernourishment, and because one medicine causes another side effect, so another doctor writes another drug for that medicine side effect. So we'll discuss what is that cascade. So this is what happens. 10% of the emergency admissions are due to adverse drug reactions that can be due to falls or delirium, and that leads to increased mortality and increased stay in the hospitals. So this is what happens. So non-adherence, falls, undernourishment, increased healthcare cost for side effects. They can cause mental confusion, and the older people become more frail with multiple medicines, with irrational medicine if he is consuming. So this is what one of the largest study has shown, that 57,000 admissions, and 3.2% were due to adverse drug reactions, and out of which 91 were easily preventable. So most of the side effects, as Dr. Grewal sir was telling, that the drug side effects can be prevented and given a good life, quality of life. So when the older persons comes to us, the first thing we ask them is, oh, show all the medicines, bring all the medicines that you are doing. So what right medicines, strike off the unnecessary medicine, tell them to continue what effective medicine is there, tell them what are the harmful side effects of the medicine so that they can attend, ensure that it fits in their economic job, monthly pension, and you have to share a plan that, see, look, I am looking for, I want to stop this medicine, and you have to consider for this, let me know for the next time. So you have to involve the older persons and their family members in the decision making. So polypharmacy, they can be rational or irrational, that's what I was telling you. Again, if you look at this prescription scenario, so what is more important is the amitriptyline and non-amitriptyline are from the same category of drugs that has been prescribed in the same person. And if you look at the red dots, methacobalamin, 1500 millimicrogram in all the three medicines, and almost he was popping up 4,500 microgram of methylcobalamin every day. So this is how the side effects takes place, and it is our duty to ensure that these are cut down. So again, if you look at this irrational polypharmacy, the patient is receiving telmisartan, hydrochlorothiazide, amlodipine, and also is receiving telmisartan, cilindipine, and metoprolol. So amlodipine and cilindipine are from the same class. So though he is taking metoprolol, telmisartan of 40 and 40, 80 milligram, that is the highest dose. But again, the drugs of same class have been used in these patients. So this is what is we call as an irrational polypharmacy, should not have been practiced. This patient who had come to us was taking 13 medicines And what actually he required was only these 4 medicines for his prostate hypertrophy and heart failure, and he is only with these 4 medicines. So that is the duty of geriatricians. What we are doing, we are just cutting down. Our own postgraduate students who pass in geriatrics and go back and start practicing, they keep sending the photographs of this. Sir, today I found a lady with polypharmacy. See, 115 drugs they have prescribed, and I just stopped everything what is required for our route. And see, this is how the even the clinicians they are doing their job after training. So this is the old man. Of course, his photograph is published with his permission. He is taking these many medicines, and these are all required for his disease. So that becomes an appropriate polypharmacy. This is the old man, keeps taking so many medicines of no use. There are multivitamins, painkillers, antacids, sleeping pills, so many multivitamins, and everything is there. And when we ask him why you're taking that, you don't require. The very polite answer he said was, sir, if I don't take these medicines in a whole day, I don't get that confidence that I will wake up tomorrow. See how they think. So when we talk to the older persons, their thinkings are varied. Okay, he says that if I take all these medicines, I feel comfortable that I'll be waking up tomorrow. So this is, but it was all an inappropriate polypharmacy he was consuming. So the same tablets, alprazolam, natrazepam, clonazepam, so many polypharmacy. We get such photographs from various corners of India, what is happening and how to solve this. Even older persons are very smart. You have to just look at the prescription, what they have brought. Apart from the drugs that you prescribe, he is taking nimesulide. See, very smart guy. He's without you know that he is taking nimesulide. Of course, Jandupam and gasolemon is taking. So we have to consider what all medicines they are taking apart from the prescription that you are given. This old man has received prescription from with even the Ayurvedic and homeopathic medicines that are mixed. So according to Supreme Court of India, this is not expected from the allopathic doctors, and this should be avoided because we don't know which medicines will lead to drug-drug interactions. Now coming to the brown bag concept, what we do in the brown bag is help to reduce the adverse drug reaction. We identify, tell the patients to bring all the medicines that they're taking. This is the lady who has brought so many medicines that she was taking once in a while and daily some regular medicines. And once we sat and sorted out, all she required was only these 5 medicines to be taken every day on the regular basis. So this is what is called as brown bag review. And we do in all patients. Like it is not that they should bring in the brown bag, as you can see here. It is not. Luckily, she has it carried in the brown bag. The name of the concept is brown bag. You can carry in any other books. So these medicines should be sorted out, remove what is not required, and advise them that this is only what you have to consume every day unless you develop a new problem. Now I was telling you cascade. What cascade is happens in the general practice here is most of the older persons are prescribed amlodipine as antihypertensive. After 15 days or 30 days, they develop swelling of the lower limbs. They will come to another doctor. Then he records the blood pressure and he says that he will add an diuretics for that. So this should not happen. This is called cascade. There is a one drug we added. Over that, the side effect it is there, and to treat the side effect, we are adding another drug. So this should not happen. This is called therapeutic cascade or a drug cascade. Now, most of you may ask, is there any policy to prevent this polypharmacy or irrational polypharmacy? Yes, there is a stop criteria. There is a start criteria for the geriatricians. Always also a BIS criteria. So what is that? We will tell. Start criteria is it stands for screening tool for older persons to alert to right treatment. Start a right treatment for him, which is missing. Stop is potentially inappropriate prescriptions. You stop some medicines. So in start criteria, 34 potential prescribing omissions if you identify, and you should advise. Now see, you are diabetic, your kidney has to be protected, you must take ACE inhibitor. So that becomes a start criteria if patient is not taking. Stop criteria. There is something called stop criteria, STOPP. So it tells us which medicine should not be given above 60 years, above 70 years, above 80 years, during the end of life care. Those who are bedridden, there are certain medicines which should not be given. That comes under stop criteria, and accordingly, we have to stop those medicines which are inappropriate for the older persons. BS criteria tells us the potentially inappropriate medications for the older persons, and accordingly, we should follow that criteria and remove the medicines. Now, again, if you look at this prescription, what is happening here is there are so many medicines, okay, and he is taking Anzate, which is a potential drug for to produce falls, okay, and then Ganeton, Rabium DSR contains both the prokinetics, okay, and Telmikind, here's 80 milligram already is receiving. Over that, another 40 milligram is added, so that accounts to maximum more dose of what is recommended for a 82-year-old female. So that is what you should understand, and we have to try to reduce such complications in the patients. So again, sir will understand this. So amlodipine with atenolol, telmisartan with metoprolol. So 2 beta blockers of groups have been added in this patient, which is again not required. So we should sit and sort it out. So coming to the last concept that we talk about is deprescribing. So whenever the older persons are on beta blockers and benzodiazepines and selective certain receptor inhibitors, we should never stop suddenly. These are the 3 medicines which you should not stop suddenly. Okay, so it should continue, and if it is really creating problem, then taper it and replace with the other medicines. So deprescribing is a process where we need to taper, stop, discontinue, or totally withdraw the medicines only to improve the outcome in the patients. So what are the problems now with the deprescribing? So increasing numbers and effectiveness of medications for chronic diseases. For the guidelines are coming for each disease, there are 3, 4, 5 medicines to be taken. So if you add 3 medicines for one disease, so older person having 5 diseases adds to 15 medicines. So again, guideline based, if you start practicing, it becomes more problematic. Pharmaceutical advertising has a deep impact on older people. अरे टीवी पे दिखाते हैं, पेपर पे आता है, पेपर पे बड़ा बड़ा एडवर्टाइज आता है कि ये दवाई ले लो, वो दवाई ले लो, और आप बोल रहे हैं मत लो. So this, they question us, the older people, they question us. So you are telling not to take this. अरे पेपर में आ रहा है तो बड़ा आ रहा है, तो they think that it must be something big. Okay, so medicalization and pharmaceuticalization is happening, and ease of pill administration in compared to changing personal behavior. And they think that if I take this tablet, I will survive because this is a magic pill, and so many things that older people are facing. And this is how the challenges the physician comes across. So there is a stewardship for deprescribing also, or polypharmacy also. So that is what sir was emphasizing, that what we can do for these patients. So medication review has to be done, and a geriatric physician or a family physician or Gravel sir can help in deprescribing the unwanted medicines in the older persons, and inform the person that these are the drugs which should not have been taken, and you can do a follow-up regularly that after stopping the drugs, has it developed any problems or issues. So our role as a clinician, once a fortnight, brown bag check in all the older patients coming to you. Take out the duplications outrightly, we can do. Are all medications indicated? Stop the medicines which are not at all indicated. Counsel regarding use of allopathic and non-allopathic medicines that can cause interactions, and regularly inquire about other medications that they are taking from the counter or from some other source. So review frequently. What we had done in my hospital is we have put such a big board, and there people are informed that next time when you come, you bring all the medicines, whatever you're taking, and we will sit and review with them. So to enhance compliance, we have in my own hospital OPD, we give these papers or packets which has zipper, and these are polythene. So we have mentioned that in the 3 languages, morning English, Hindi, and Kannada. And those who cannot read, we have put the photographs. This is early morning sun, afternoon sun, and midnight moon. So that even if they are illiterate also, they will understand this has to be taken in the morning, this has to be taken in the afternoon, and this has to be taken in the night. So this is our practice of enhancing the compliance of the medicine in the older people. So no pill for every ill. That is what geriatricians and the physicians will do. Always start a low dose and go slow high. Do no harm should be the first principle of any clinician practicing. And one size fits all, no. Just because Mr. X is taking medicines, it will work in Mr. Y. No, it will not work. So match drugs to the specific diagnosis, avoid cascade, avoid drugs with similar actions, and always you should consider cost here, especially in my place. We get a lot of people who are very poor, and we have to consider costs and always communicate clearly that this medicine has been stopped for your own benefit, and please avoid taking this medicine because this will cause a fall, this will cause an incontinence, so many things, constipation, right? So this is what we are doing, and we must take in account the potentially inappropriate medications, nutritional deficiencies, that is what is caused by multiple drugs, and overprescribing, misprescribing, and underprescribing has to be addressed in the general practice. So this is the JAMA page for a patient's benefit. The same thing which we have discussed has been summoned and put it in the nicely in the one page for. So again, I just like to conclude that William Osler said a young physician starts life with 20 drugs for one disease, and old physician ends with one drug for 20 diseases. So this is how the pharmacy clinicians.
Very commonly elders को दर्दें होती है. They come and say, डॉक्टर बहुत पेन हो रहा है, सारे टेस्ट करा लिए, सब नॉर्मल है. This is, I would put this question to Dr. Amli, that which of the complaints in your practice have the elders been prescribed most useless medicines, say for constipation, for body ache, for sleep? ऐसा कौन सा symptom है इनमें which you found that for maximum number of useless medicines are prescribed for pain or for sleep disorder or for constipation? ऐसा कोई can you just scan your practice and identify?
Yes, sir. One of the commonest is general weakness.
General weak.
Weak people keep coming telling मैं weak हो रहा हूँ, मुझको weak weakness लग रहा है. What is the weakness? He can't define. When we ask them, आप weakness मतलब बताइए आपको क्या हो रहा है, they are failing to define. And by the time they have come to us as a geriatrician, they are already 5 to 7 multivitamins being taken, some injections taken, but still they don't have relief of that. So general weakness is not to be treated by multivitamins. Then we have to find the cause. What is the cause for general weakness? Then we have to treat accordingly and not that.
I think this is a big message to all the elders. Please, for heaven's sake, दवाई के अंदर ताकत मत ढूंढिए. दवाई के अंदर ताकत मत ढूंढिए. अगर आपको कमजोरी है तो उसकी वजह पता करिए. And if all tests are normal, then that comes under the category of geriatric giant. Just for the sake of knowledge of everybody, Dr. Amri, in your practice, if you have found कि आपने सारे टेस्ट कर लिए, arthritis test, all tests, electrolytes normal, and still the person says that I've got severe body ache, what is the safest suggestion that you give them?
It's a very good question, sir, and it is directly telling us that look at his mental health.
Mental health.
There is no other issues. There's no other issues. First, look at his mental health. Where is the problem? Talk to him. Are you a victim of abuse? Are you feeling loneliness? Or is somebody threatening you? Or you're not getting good sleep? Or you're feeling insecure?
Beautiful.
If these questions are coming and answers are coming to this, then, sir, as you rightly mentioned, we have to think what is the reason for that. And this is the way older persons want to express.
Yes,
sir. Because they don't come and tell directly that I am a victim of abuse. They, if you, as you mentioned, that you have done thoroughly examined, and even I do echocardiography for your kind information. I do echocardiography.
That's right.
And ensure that his cardiac activity is good, and his ejection fraction is 60 and above. Despite that, he is having general weakness or multiple symptoms. Apart from all other reports normal. Think of mental health. Is a depression or is in suffering from loneliness or is a victim of elder abuse.
देखिए, एक शिकायत elder की can open such a big possibility. And Dr. Amli ने mental या उसकी तकलीफ को last पे रखा है. He has clearly said that all investigations first carried out. If nothing is found, then you have to start thinking on those. And what he said, because of those problems also have a language. आप देखिए, आप किसी के घर जाके खाना खाते हैं, बहुत अच्छा खाना, आप कहते हैं बहुत अच्छा खाना. Can that अच्छा be, measured? No, you can't. So emotion cannot be measured. It can be expressed. But the elders feel scared to say, I'm sad, I'm getting beaten. So they have a different language. So they will come with physical complaints, and it is left to the doctor to assess after thorough examination to come to that conclusion. Therefore, all of you, the message, Dr. Ambli is a very senior geriatrician, and therefore the message is that your regular visits to your regular doctor may not pick up the geriatric giants. ये अब आपको ज्ञान होगा. मेरा स्वास्थ्य मेरे हाथ का मतलब है कि आपको पता होना चाहिए कि मेरी तकलीफ के लिए शायद कोई दवाई नहीं, कुछ और मेरे को सजेशन देंगे. So I think that was the purpose for today's question. I please invite anybody who wants to say anything or ask anything. Yes, Dr. General Kalra sir, please unmute yourself, sir. Sir, General sir, I can't hear you. General Kalra sir, I want to, you have to unmute yourself.
I just want to say,
Hello, can you hear me?
Yes, sir, please go ahead, General sir.
all elders are already half doctors because they know how many medicines they have been taking, and elderly people.
एक minute, Goel sahab, एक minute. You have made a very dangerous statement. You said all elders are half doctors.
Yes, because they are experienced. They know.
No. Most dangerous statement.
But let me understand. Let me explain.
Ji.
Everybody knows for thyroid, for diabetes, for pain, for gas, for constipation, everything they know, and they start taking that medicine.
No. Goel sahab, no. Yes, Dr. Amri, please.
Sir,
I'm talking about-
your statement is true because once a diagnosis is done,
That is okay.
you need a doctor to make a diagnosis of thyroid disease in you.
अपने आप नहीं.
And अपने आप तो कोई, you know that you are taking medicine for thyroid, so that is not a rocket science. So that doesn't make you anybody a doctor. It is a doctor who makes an attempt to make a diagnosis in you, whether thyroid is there or not there, diabetes is there or not there, depression is there or not there. Then the medicines are started. Okay. As you said, sir, I appreciate Goel sir that.
After test only.
Goel sahab, एक minute. You said that most elders know कि उनको कौन सी बीमारी चाहिए.
कौन सी दवा लेना.
कौन सी दवा. This is the most dangerous statement.
Correct.
If you are having, I'll give you an example. Dr. Ambli will come in. If a elder person is having burning in his chest and saying मुझे डकार आ रहे हैं, he will say मुझे gas हो गई, and he will take an antacid because experience in last 20 years he's been taking antacid. But do you know, sir, he may be having a heart attack. Therefore, please understand, do not take medicine. Dr. Ambli, you will please add to this line. Do not take medicine by assuming a disease. You can take crocin, you can take paracetamol, you can take Digene, but don't take any drug assuming a disease. Dr. Ambli, how often have you felt that
many times.
Emergency.
Now, the Goel sir has raised a right issue. We have to address this issue because he is right in his issuing. No problem.
Sir.
The problem is the diseases in the older people don't present with classical symptoms as they are in middle age. For example, a patient with myocardial infarction, heart attack, he will come to with burping, gaseous discomfort, pain in the abdomen, not chest, giddiness, or fall in the bathroom. But he never complains that chhati mein dard hai. Never he complains.
Never.
So this is how the older persons differ from the younger generations. And sir, Goel sir, you are right because you know you have your friends have got some diseases. You know these medicines are given. But should I start thyroid medicines for this gentleman A or gentleman B or gentleman C. How much dose I should give for each is different. It cannot be generalized for all people above 60 years that thyroid है आपको ये दवाई ले लो नहीं है लेकिन जितना मात्रा में देना how much you have to take, what you should monitor, and we have to find the cause.
And similarly, Goel sahab, if somebody, for everybody, ये सबके लिए है, very common एक situation आता है, lot of elders see their own blood pressure. मेरा blood pressure 150/90 हो गया. अरे मेरी वाइफ ना एम्लोडिपिन लेती है, मैं भी 2.5 milligram ले लूं. Very common, and the moment he's taken 2.5 milligram, he is collapsed. So anyway, what Goel Sahab has said has reflected the mind of 98% of elders. Goel Sahab, जो आपने कहा 98%, therefore Dr. Ambli is saying, आपका एक perception है जो बहुत common perception है. But is that elders medication, you know, many years ago, we used to say one tablet 3 times a day. How old is the child? 8 years. Okay, half kar do. That used to be the method. But today, babies are given medicine by weight. 0.5 milligram per kilogram body weight, not because of age. Now, same thing has happened for elders. It is not you are elder, so you can take this. No. Polypharmacy issue is coming up because elders are not following a scientific method of treating themselves, nor are doctors following. Both are at fault. That is what Dr. Ambli has said. So I think that issue is sorted out.
I agree with you. And this is what in the opening remarks, Dr. Grewal sir told that not many physicians are aware about polypharmacy, and many older people are also not aware about polypharmacy. The older people so innocent that they go to a doctor, whatever he writes, he brings, takes it promptly and sits in the home. Fine. When he develops a problem, the children see that he is not taking these 20 medicines, there is some issues with them, then they change the doctor. Okay, they change the doctor, and when they come to a geriatrician or a physician who is well versed with handling patients with polypharmacy, irrational polypharmacy, there the solution comes.
There is the solution. I think Scholar Bedi sir and बाकी सब elders भी, जो patient factor है, one issue which is Dr. Ambli must have faced, what elders do is, if they have gone to an orthopedic surgeon, the next day they get pain in the ear, they go to ENT surgeon. But they don't carry the prescription of the orthopedic surgeon to the ENT surgeon. वो तो हड्डी वाला है ना, उसके कान में क्या मतलब है? And the orthopedic surgeon may have written an anti-inflammatory medicine, and the ENT person will also write an anti-inflammatory, and they will start taking both. So as far as our suggestion to all of you is, whenever you visit a different specialty person, carry all your, that is why, carry all your medicines, carry all your prescriptions. Sir, मैं ये खा रहा हूं. That is important of how you can prevent polypharmacy within yourself. Number 2, make sure that when you prescribe, you have to start doing this, all of you. Please ask your doctor, is this medicine very essential for me? Can it be postponed for some time? ये बात पूछिए. डॉक्टर चुकन्ना हो जाए कि ये मेरे से पूछ रहा है, नाराज हो जाए, कोई बात नहीं. But ask whether, how often, Dr. Ambli, that a person has asked you, should I really have it?
No, sir, in our geriatric practice, we don't come across such patients because they are happy when we cut down the medicines. So they are happy. And as you rightly mentioned, sir, all the senior citizens here, I request you folded hands, please carry your medicines and ensure that your consultant has a look in it. प्लीज रिक्वेस्ट हिम, सर ये दवाई देख लीजिए, प्लीज देख लीजिए, क्योंकि मैं ये ऑलरेडी ले रहा हूँ. Otherwise, he will end up with writing another antacid, he will write another anti-inflammatory drug, another antibiotic. So 2 antibiotics, 2 painkillers, 2 antacids, and next day morning you will end up in my clinic with loose motion and diarrhea or all those things.
Very common. All of you must say, Lekha Chubji's question, Dr. Amli, can we take generic medicine which are cost effective in any specific between a branded medicine? Do you
Sir,
have
it is an open thing in our geriatric practice. As I told you, in our place, many patients are poor, so
So
we
they take
don't
them.
put
So
any
there's no harm.
restrictions for
There's no
them.
harm.
No harm. You
No
take
harm.
whichever
Please go ahead.
medicine you want to, if you are affordable. That is for
See,
left to you, but you take it.
that
Our
is important.
assurance is
See,
you just take the medicine every day. Compliance is more important than the quality and the.
और देखिए दो इश्यूज आते हैं पॉलीफार्मेसी. एक है when you visit two different doctors, both write different medicine. Secondly, आपको सुबह उठ के सिर में दर्द हुआ तो डॉक्टर अम्बली को फोन किया. डॉक्टर अम्बली ने आपको कहा यू टेक दिस मेडिसिन which has some anti-allergic also. Then in the evening, the elder starts feeling scared कि पता नहीं I will be able to sleep or not. So he rings up his friend, not the doctor. He rings up his friend. यार तूने उस दिन नींद नहीं आई थी, तूने कौन सी गोली खाई थी? यार मैंने ये गोली खाई थी. Now in the morning, the gentleman has taken one tablet which has slight dizziness, sleepy effect, and the evening he takes another medicine because the friend has told him. And at night he gets up, he feels giddy, he falls down, he gets a hip fracture. This is what we are talking about, the dangerous effects of mixing of medicine because of self-medication.
This is what I am saying. Every doctor, elder say that I know for myself.
So
Every
that,
elder.
Goel sir, that is a question responsibility of the individuals.
Yes.
And I am again saying, with due respect to Goel sir, please elders don't say I know my body. You don't know your body. Let me be very emphatic, because you know your body which was 45 years ago. आज की तारीख में जो मेटाबॉलिज्म चेंज हुई है वो इतना चेंज हो गया है that is resulting in major side effects in the elders. नहीं, मुझे पता है कि मेरा ब्लड प्रेशर ना, जब मेरा सिर घूमता है तो मेरा ब्लड प्रेशर होता है. There is a thing, I think if you all remember, Dr. Ranjan का लेक्चर था. He says mini strokes, छोटा सा स्ट्रोक होता है, but who will check it? Not you, because थोड़ी देर बाद ठीक हो गया. आपने ना एक एस्प्रिन की गोली खाई, मैंने पिछली दफा हुआ तब भी ठीक हो गया था. That is what leads to polypharmacy. Anyway, anybody else, any questions? Yes, Avinash ji, please go ahead.
एक और सजेशन देना चाहता हूँ.
Doctor Saab, is it advisable to go to a physician for
That's right.
for different problems? And
Dr.
tell him that what all I am taking. Should
Yes.
I continue it or?
Just ask, Avinash ji, what are you asking?
Is it advisable to go to my physician and tell him that I am taking all these medicines? So
yes,
suggest.
very good. You go to orthopedic surgeon, come back to your physician. You go to ENT surgeon, come back to your physician. That is the way to do it. Somebody else was also speaking. Yes,
I was just suggesting one thing.
sir.
One problem with the elderly people is they get confused when we are giving medicine BD, TDS, CIQID and all. Preferably, it is suggested when I have given a lecture to these postgraduates in geriatric medicine that you give them possibly of different color, not give more than twice, either once or twice. And if different color, and tell them this is the medicine which you take in the morning of this color, this is the medicine of this color you take in the evening. And only way, if they can remember easily, if they are only twice or once every day. Unless, as you say, polypharmacy is the more many number, where confusion comes. But still, if they are preferably given once or twice in a day, they'll be able to remember and take it.
Very nice, very nice. Thank you, General sir. Yes, again I quote Mr. Goel. Very many elders, जो गोयल साहब ने कहा, 99% elders say this to us, I know my body. There lies the problem. I want to say to everybody to start saying for themselves, मुझे अपना शरीर नहीं मालूम. जो चीज मालूम है वो बीमारी नहीं है. जो चीज मालूम है वो बीमारी नहीं है. We are looking for dangerous issues, falls, heart attack, strokes. We are not looking at 3 दिन की लैट्रिन नहीं आई तो मैं सेल्फ मेडिकेशन ले लो, चूरन ले लो, 4 दफा टटियां करो जितनी मर्जी, but not neglect the life threatening diseases. And elders cannot, elders can नहीं, nobody can differentiate. वो जो क्लासिकल स्टाइल होता है ना, यो हार्ट अटैक होके ऐसे गिर रहा है, वो पिक्चरों में होता है और सब नकली होता है. सच्चाई में किसी को नहीं पता लगता कि मुझे हार्ट अटैक हो गया. देयर इज ए लो हेल्थ सीकिंग बिहेवियर. बिहेवियर इज इनहेरेंट दैट डॉक्टर के पास अवॉइड करना है. दैट इज इनहेरेंट इन देम. कोई तो गए तो दवाई लिखेंगे. नाउ व्हाट Shravan is saying is something different, but Dr. Ambli, with this mindset, it can lead as a risk factor for polypharmacy, because when they go worried, they have already delayed their own symptoms, then they want the best of medicine, because there is a thing called dependency on medicine. So people who delay going to a doctor also are those people जो कि दवाइयों पे बहुत dependent होते हैं. What do you say as a concluding remark, Dr. Ambli?
Yes, sir. With due respects to all the issues raised by the participants, they have brought the real issues, and we respect it. But that is what is happening with us. As a geriatrician, we come across these issues every day, and how we to tackle, how to handle. And Dr. Sharon was telling that they're not now bringing the paper. So what I do in my practice is the son who comes to with the accompanies the father or the grandson comes, I tell them to take the picture of the whole OPD sheet and the reports in their mobile phone. So next time, even if he doesn't bring the papers, at least in mobile phone, they will have the records, and we will know. And older people are very smart. If they don't bring the paper, at least they will be having the strips of the medicines they carrying in the pocket. So with that, at least we can solve major of the issues. But as Dr. Goyal sir said and McKin sir said, a lot of issues are there, yes, and there are multiple issues in the same person. And in a geriatric OPD, every patient has his own issues. So we have to address many issues in many people and multiple issues in the single person. So
Very
that is the full of challenges. And to some extent, there is a level of patience for a clinician like me also. But once we lose the patience, then we tell them, you come tomorrow, better come tomorrow, then we'll discuss. Because I don't have now that energy to take.
I think
so we
you
tell
have
them,
a
come back tomorrow, and then we'll sit and talk about this.
Very nice.
So
I think I invite everybody to give a big hand to Dr. Ambli for this wonderful lecture, wonderful topic, and presented to us so well. Thank you so much, Dr. Ambli, once again. It's been a pleasure. And Marwa ji, conclusion में कुछ कहेंगे आप? आप म्यूट पे हैं, आवाज नहीं आ रही.
अब आ रही सर, अब आ रही है.
अब आ रही है सर.
डॉक्टर अंबाली को बहुत बहुत नमस्कार, और आपको भी सर नमस्कार. सर मैंने तो एक ही बात सुनी थी आप लोगों से, जो सबसे अच्छी मेडिसिन है, कहते हैं बेस्ट मेडिसिन फॉर ह्यूमन बीइंग इज केयर एंड लव. सम आस्क,
और जो आपने जो बेस्ट मेडिसिन बताई है वो किसी केमिस्ट के पास नहीं मिलती. मुश्किल तो यही है.
मगर आपके पास मिलती है सर. आप दोनों के पास मिलती है. तो सर किसी ने कहा कि बेस्ट मेडिसिन फॉर ह्यूमन बीइंग इज केयर एंड लव. सम आस्क, अगर काम ना करे तो डॉक्टर अंबाली ने बड़े बड़े मुस्कुरा कर कहा कि आप डबल कर दीजिए डोज को. थैंक यू वेरी मच सर.
थैंक यू.